Good evening. So the next few minutes, we will discuss about treatment of MET exon 14 mutated lung cancer. And the disclosure for this session, we know it's a sponsored symposium. So we will be discussing about the approved drug Capmatinib in India. And as of now, at least I don't think there's any other approved therapy specific for this disease currently in India. So MET mutations, this is not something new. We figured this out long ago in small cell lung cancer, but we didn't know what to do about it. Later on, as and when we started treating more and more EGFR mutated patients, we learned that this is maybe an important mechanism of resistance. And then newer drugs were developed to target this. So we had Savolitinib by AstraZeneca, then we had Amivantamab, the bispecific EGFR MET. Also at the same time, we have Capmatinib and Tepotinib just to target this. And it's only more recently we realized that actually this MET alteration could be of many types, could be amplification, it could be increase in gene copy numbers, or it could be an exon 14 skipping mutation. And it's actually the exon 14 skipping which is the main mutation which makes it a driver mutation in a subset of lung cancer patients. So how common that is, not sure if we have proper data from India, but I'm sure it's easy to get it because now most of our panels have MET as part of it. But what we see from the West is about 3%. It could range anywhere between 5 to 22%, depending on what you're looking at. And there is some suggestion that this is possibly more common in older people. Now, per se, whether having this mutation is a poor prognostic feature, difficult to say, because when you see comparisons like these, even though they look like that these people are not doing that great, but in the comparator arm, you have people who may be getting maybe a osimertinib or an alectinib. So it's difficult kind of comparison. But what is interesting is if you see how do we select patients in the clinic. So if you only check for EGFR and ALK, then as by default, you would be offering them based on the PD-L1, mostly chemoimmunotherapy. And so if you have a patient where you have missed this mutation and the patient is on chemoimmunotherapy, how likely is he? What are the response like? Again, the data, the numbers are small. It's the waterfall plot on your screen. You can see that not many patients actually have done well on immunotherapy combination. And even if you look at the tumor mutation burden, the pink, I don't know if you can make out, most of those patients had a higher tumor mutation burden. In spite of that, the chemoimmunotherapy or immunotherapy combination resulted in a PFS of only 1.9 months. So this is something which we make note. Now, so how did this whole story started? So initially, we all know that we had drugs like Crizotinib and Cabozantinib, and also there's another drug called Gelasatinib, and then became Capmatinib. So initially, when patients did have any MET mutation detected, either earlier or subsequent course of treatment, they were given these drugs. These older reports show us that their median overall survival was about 24.6 months, which is very good for a metastatic lung cancer, and a median and patients who never had any MET TKI and they did have that alteration, their median OS was only 8 months. So after having established this as an important driver, and after having kind of convincing, I hope I'm able to convince all of you that we do need to find this out, because if you miss it in your patient before deciding first line therapy, there is a possibility that you may not be giving him the best treatment. So of all the available MET inhibitor, why do we need so many? What is the difference between Capmatinib and the other available agents? One thing is it's about how specific it is, how selective it is. So so if you see here the IC50, Capmatinib has the lowest IC50, 0.6 as compared to say Savolitinib or Tepotinib. And if you compare that to Crizotinib, that's 22.5. So lower the IC50, more selective, less side effects is how you look at it. So as of now, we know the drug has got approval, but we all need to know based on what data, right? So we know in these rare cancers, it's very difficult to do large randomized trial. I mean, many times, even if what we see, all of us are convinced that this is an active drug based on small trials, but they're phase 2. And initially, when Novartis tried to develop this, they decided to try this drug across various MET alterations. It could have been a gene copy number aberration or amplification or mutation. So just focus on the blue part. So they had various cohorts, and the main thing was what is the alteration, and whether the patient was treatment naive in first line or subsequent lines. So we're going to focus mainly on the cohort 4, 5B, and later on they added on a expansion cohort 7, and all these cohorts had this exon 14 skipping mutation. Being a small single arms trial, your endpoint was only overall response rate, with secondary endpoints being your PFS and duration of response. So we do have good numbers. When I say good numbers, is like if you compare to like for an NTRK fusion or in some other mutations, we have 20, 30, 40, 50 patient data. But here it's close to 100 patients by combining cohort 4 and cohort 5B. The striking thing here is that if you look at the median age is 71 in years. So that's all. I mean, most of these patients are senior people. More than 65 years, if you see, almost 80%. So again, if you have an old person, I mean, maybe it's more likely that this patient may have this mutation. Now, how does smoking play a role here? It seems like about 40% of them had some history of smoking. So, and also another important thing is that this is a mutation which may even be present in squamous cell carcinoma. So some of your centers, when you don't sequence squamous cell carcinomas, that's, I think, is not the correct practice. We should be sequencing every patient except maybe small cell lung cancer. And then if you see in these cohorts, the number of patients who had brain mets was about 15%. And if you look at, does this mutation correlate with gene copy number? Actually, no. The spread was kind of even across low and high. So the kind of treatment these patients had before they went on to this study, the 28 patients were treatment naive, so no treatment. And then for the remaining, if you see, majority had 1 or 2 lines of therapy, and immunotherapy use was used in about 30%. So that goes along with the routine practice of using chemotherapy or chemoimmunotherapy in the first line. The endpoint of the study was response, and if you see, in patients who were pre-treated, that is, they were in second, third, or later lines, the response rate was 40%, and which is pretty good, right? We all know what is the response rate of docetaxel in second line, and then if you add stable disease to that, and the clinical benefit rate or the disease control rate goes up to almost 80%. So that was in pre-treated patients. Now, if you look at in patients who have never seen any treatment before, the partial response was 60 to 64%. Which is pretty impressive at par, I would say, with the ALK inhibitor or the EGFR inhibitor. And the disease control rate going up to 96%. So definitely, if I am a patient, I would want to know if I have a MET exon 14 skipping mutation before deciding my first line therapy, because these waterfall plots are pretty impressive for an oral therapy, which is so well tolerated. I'll come to toxicity. And so literally, if you see here in this thing, the number of patients who progressed while taking this drug was only 1 patient in this entire cohort. So now response is okay, but how durable is the response is the next question patient is going to ask you. So duration of response. So here, if you see, the numbers are 28 and 19. That's because only people who have responded are on this Kaplan-Meier curve. And you see most of them actually have this response going for about a year or so. If you see, that is if you give it in the first line. So the first line treatment naive PFS is 12.58, and for subsequent line patients it's about 9.72, which is compared to any other treatment, even take docetaxel or immunotherapy or even combination chemotherapy. This is probably a better agent to use in later lines. Now, if you see progression-free survival, this is again in patients who were treatment naive and pre-treated. It's about 12.4 versus 5.4, and the swimmers plot here shows you that for people who respond, the arrow marks actually shows you they are continuing to respond. They're on treatment. So again, this is, I would say this is one of the first drugs we have it here, and this is at par with any other TKI which we use it for at least for the first generation TKIs and the second generation TKIs which we have for EGFR and ALK mutation. Now, activity in the brain is something important. We were talking about use of radiation or no radiation. If we have a patient with exon 14 skipping who has brain met, should we be doing radiation? Now, again, if you see these trials did have some patients, and they were like 13 out of 13 patients, 7 of them did have a response. So there is, and if you look at stable disease also as intracranial disease control, 12 out of 13 patients. So the message here is you don't have to jump with radiotherapy, but then the point is because still early days, less number of patients data, not like we're not so convinced as we are with lorlatinib or alectinib. So you should do a repeat scan little early. I wouldn't wait for 3 months. Maybe I will scan it within 6 months. 6 weeks or 12 weeks to make that decision. Now, does the kind of mutation matter? The conclusion is no, it doesn't. Whether you have a single nucleotide variation or any deletion, it doesn't matter. So all what I've just explained to you is actually put together and it's published in NEJM 2020. The results they combine the cohorts and when you look at it all together, you expect a response rate in the first line close to 67%. And disease control rate close to 100%, except for that one patient. And in later lines, the number comes down, the response rate comes down to 40%. And the other thing is how rapid the response is. So across these cohorts, when we see that if you define an early response as a response at the first scan, that is at the time of 6 to 7 weeks is when we do the scan, and the number is almost 70% of your patients who are going to respond would respond at your first scan. So that's something which we all can actually hold on, and even in the absence of a randomized control trial, 7 to 8 weeks is not a long time, and we can definitely give this agent and then see whether the patient has a response and then make a call on timing of use of chemotherapy. And then these are the progression-free survival for patients in second and third line, and you see we already have discussed. This is the published data. Now coming to toxicity. So again, now I mean, we were all used to thinking that TKIs are less toxic, but we are learning from drugs like lorlatinib, afatinib, dacomitinib that that's not the case. So here, if you look at it, the most of the side effects listed here, if you see grade 3, 4 is in single digit, so that's a good news. Peripheral edema seems to be a class effect of this class of drugs, which is present even with the other molecules, and some edema is expected in close to half your patients. When I look at these tables, I usually look at what is the treatment discontinuation rate due to adverse events, and that thankfully is low, and this seems to be a good, well-tolerated drug. So in conclusion, the take-home messages would be that please do not miss an exon 14 skipping mutation, and the best time to test it is at diagnosis, not for in later lines. If you have these mutations, the response rates, the PFS, the duration of response, they're all convincing enough for us to favor this over and above chemotherapy. In India, currently, we are recruiting for a trial, which is a geometry trial, which is a randomized control trial in the second line. The control arm has docetaxel, but there is crossover. So if your patient is in second line, I think you should find a center closer to you and then refer the patient over there. But for all other patients, patients in the earlier lines or unfit patients, the drug is available for use. And with that, I'll close. Thank you. Thank you.